Yes, he's an oncologist from Seneca, so please give him your full attention.
Thank you. Well, I appreciate the invitation. When Amanda talked to me, I wasn't sure how eclectic the group might be as far as what your professional plans were. I mean, I know there's a nursing school here. She told me it really wasn't more nursing. This was more medical profession type oriented stuff. So I'm going to present this as if, you know, you're looking at medical school or dental school or health administration or something of that nature. It's part of the medical profession. So as Amanda said, I'm an oncologist, and oncology comes from the root onco, which is Greek for tumor. So I'm a cancer specialist. And you do a fellowship to train to be the subspecialist. And it used to be that oncology was a 2-year fellowship, so after your residency, and I'll go through these whole processes here, but there was also a 2-year fellowship for hematology, which is taking care of blood disorders. But so many of the blood disorders kind of overlapped, and you know, the people didn't know who to call. So if you have a leukemia or lymphoma or something like that, there was this kind of intersect between the hematology and the oncology. So most of the programs now are combined. So it's a hematology-oncology fellowship. And heme, of course, is blood disorders. So that's a 3-year fellowship, and at the end of it, you get boarded in hematology at hematology boards and oncology boards. So how did I get to this point? Well, you go to college, and you know, back in the early 70s, very early 70s, when I was in college, you know, there was pre-med, and that was a defined major. Now I don't know that pre-med is a major. You take chemistry or biology or some other kind of science-oriented thing. Although, much to their credit, medical schools have been open to actually have a lot more humanities as far as the pre-medical, the undergraduate training is concerned, because we're actually human beings taking care of other human beings, and while you have to be relatively smart in the sciences, you'd also like to be good at interacting with the people you're taking care of. So I remember going to the pre-medical, so I was at Duke undergrad, and so there's 1,000 in the freshman class, and the pre-med, before you even start class, there's the pre-med orientation. And it's the biggest auditorium, and there's 500, there must be 500 kids in there, and they give you this pep talk, which is basically look to your left, look to your right, and only one of you is going to medical school. So the other two plan for something else. So it was this intimidation factor to kind of weed out people to begin with. And you know, guys, if you're going to medical school, it's still pretty hard to get in. You know, there just are not that many spaces and that places. And, you know, obviously, in the last week, we plan to insure 32 million more Americans, and there are probably not going to be enough trained doctors to take care of them. So, I mean, there may be some moves afoot to actually increase the admission pool for medical school, which might be a good thing if you're a freshman or sophomore. If you're a senior, then that's not a good thing because it didn't change that quickly. So when I did undergraduate, it was basically a chemistry, biology type thing. So most of my focus was on the sciences. And you know, fortunately, you know, when I was in high school, it really wasn't that hard, and I applied to 2 colleges. I got less and less confident as we went along, so I probably applied to 13 medical schools. And those were, you know, back when we had Smith Corona typewriters, there wasn't any word processing, so you know, you're plucking those out, and you actually put the stuff in there to do the whiteouts and that. And so 13 applications took a long time. And you do the application, and then you make the first cut, you get an interview, and you go interview with some of these places. And so that process went by, and so I got into medical school, and I was at the same place for 8 years. So, and the way that most medical schools work is that you take a basic science kind of academic curriculum for the first couple of years. And then, after 2 years, 4 years undergraduate, 2 years of medical school, they actually let you see a patient. And it's a pretty neat experience. It's also intimidating, a little scary, especially when you're examining, parts that, you're not necessarily used to examining. And so there's then the clinical rotations, and in the third year, you have 5 basic clinical rotations. You do 8 weeks of pediatrics, and 8 weeks of psychiatry, and 8 weeks of surgery, which you basically hold the retractors, and then when they leave, they let you sew up the wounds and stuff. You do 8 weeks of obstetrics, gynecology, and 8 weeks of medical. And then in your third year, you kind of focus on clinical work that you want to focus on. And at the end of medical school, you start looking at your residency programs, because if you're going to do some kind of specialty, and you're going to do a specialty amongst those, as well as family practice, which again, I think if you're looking for a subspecialty, you go to these academic medical centers, which they all are. They're training people to be researchers and to be, and the focus has been on subspecialty, but there's going to be more and more focus on being a general doctor, because that's kind of what the country needs, and there's probably going to be some incentives. There's probably going to be some monies that are going to be available to help pay for your education if you go into one of these lesser filled up specialties that are necessary for us to take care of our population. So you apply for residency programs, and what did I say, 13 medical schools? All right, now I'm going to 23 residency programs, because I'm really not confident. Eastern Airlines, anybody remember Eastern Airlines? No, they're just fun. But Eastern Airlines had a ticket where you could fly anywhere but Eastern for 21 days. So you got a ticket, and you could get on a plane, and get off a plane, and get on a plane, and get off a plane for one ticket. And they fed you. I mean, there was hot breakfasts, hot lunches, hot dinners. I checked my bag, and never lost it. The only restriction were you couldn't fly in and out of the same place twice. So I was living in Durham, and I flew back halfway through this 21-day marathon to Greensboro, and my wife took me out there. And so I got through a lot of interviews, and so I ended up going to Vanderbilt in internal medicine. And the way that it works is, and this still is in existence today, once you're ready to do a residency program, you basically put out, after you've interviewed all these places, your top 5. And the places you interview with put out their top 5. There's a computer that matches you. So their highest person, you get matched to your highest program that matches you. So you have a whole program, all your entire medical school comes to this celebratory thing. It's not celebratory for everybody that shows up, but it is a situation, your wife, some of these people are older, they've got their kid there. And so that's called the match, and you'll be part of that as well. So there's lots of places where you can get intimidated, and you just have to kind of walk through that, because as they say in the business, what do they call the last person in their graduating class from medical school? Doctor. Right? So, I mean, you can find your way even if you didn't do particularly well during medical school. So residency, again at Vanderbilt, and what they did, and the one thing that you have to kind of recognize is that you've got to have a certain degree of stamina. And it is less evident today because there are rules about how long a resident can work during a week, because there were mistakes made because people were too tired and they couldn't make mistakes. We were every other night on call for 3 years. So you came in the morning and you stayed that night, you went home the next night, you usually went to bed and then came back the next morning to go home. The hour limits now are 100 hours per week. You know, most people are working, 95 or something like that. It's 40 hours a week. So it's still 2.5 times what a normal person really works. But there are cutoffs, and the issue is that when you're taking care of a patient all day, and now it comes time that you have to hand that person off, there's got to be a certain degree of communication with the person you're handing off to. So there's something lost. I mean, there's a trade-off from the standpoint that you can be too tired to take care of somebody and make mistakes because you're just not thinking right. But you also, there's going to be something lost in translation when you hand that person off too. So it's not a perfect system. And we'll talk a little bit about the fact that this country really kind of expects perfection. And when human beings are taking care of other human beings, that's just not going to be the case. The other thing we talked a little bit about, if you go into a underserved, underpopulated specialty, you may be incentivized to go that route by getting some of your education paid for. It is expensive, and I couldn't afford it, so I went the military route. So it's called the Health Professions Scholarship Program. It still exists. And there's also a military medical school in Bethesda. And that was great for me because they took care of tuition. They bought my books. I had to give them a year every summer as either an internship. We did officer training school. We did, survival training. We did some internships at one of the major military medical centers. So you had to do a summer during that time. But at the end of the time, you owed years. You didn't owe money. So there was a payback at that. They left me alone, and I was able to do a civilian residency. But there are military residencies at a lot of the major military teaching centers, which are good. And you get top-notch, and you see a lot of stuff. You see female stuff and male stuff, and anything from that standpoint. So when my residency was over with, I wanted to do I actually started to contemplate. I was in an internal medicine residency, and I actually started to contemplate that oncology was kind of what I was drawn to. And it was just because there were a few patients where you just really got totally involved in their care and in their family. There was a young lady, Vanderbilt was drew from a lot of different surrounding states, but there was a lady from Kentucky who had leukemia, and when we were putting those people through the induction therapy for leukemia, for leukemia, their blood counts got very low, and they were very susceptible to infections. And so she had a fever pretty much every night, and you'd have to go and draw blood to make sure there was no bacteria in the blood, and check the urine, and if there were any kind of central nervous system things, periodically they'd have to do a lumbar puncture. So there was a lot of time that I'd get close to that person. And it just was kind of, for the romantic part of me at that point, just something that I thought a doctor could do. So I was kind of focused on wanting to do that for a subspecialty. But Uncle Sam said, you really have to start paying us back at this point. So I got put in active duty in the military at a small base in almost Canada. And I was the base internist, which meant that there were a bunch of family practice doctors, and when they had a hard case, they would do that. We had kind of a makeshift ICU. And when you're at a big medical center like Duke or Vanderbilt or even Greenville Hospital System, you get insulated because you're always surrounded by other people you can ask questions. And when you're out there in the wilderness, you don't. And I always assumed that the referring physician from an outside